Welcome back, students. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. In Part 104, we covered the intricacies of the Advanced Surgical DRG deep dive for the maternal side, specifically MDC-14. Well, today, in Part 105 of our Inpatient DRG Masterclass, we are crossing right over to the infant side of the equation. We're going to do an Advanced Medical DRG deep dive into Major Diagnostic Category 15, newborns and other neonates with conditions originating in the perinatal period. Let's get started. Our agenda for today: 1. Factors driving neonatal DRGs. 2. The late preterm dilemma. 3. Meconium and high acuity conditions. 4. Perinatal procedure coding. And 5. Sepsis clinical validation.
Section 1. Factors driving neonatal DRGs.
So what actually drives these neonatal DRGs? It's not just about the standard diagnosis. They are heavily driven by some very specific demographic inputs. First off, your principal diagnosis must be that Z38 category code for birth status. This tells us, is the infant a single live-born or multiple? Were they born in the hospital or transferred in? From there, birth weight tiers really dictate the grouping. For example, an extremely immature neonate weighing under 1,000 grams falls right into MSDRG 790, while your normal newborn weighing over 2,500 grams lands in MSDRG 795. Also, keep in mind that discharge dispositions, like transferring the baby to another acute care facility or mortality, independently route the entire case to MSDRG 789.
Section 2. The late preterm dilemma. Here is where things get a bit tricky for coders. Clinical guidelines, like those from the American Academy of Pediatrics, define a late preterm infant as one born between 34 and roughly 36 weeks and 6 days of gestation. However, the ICD-10-CM coding rules, they are incredibly rigid. They explicitly do not classify infants with a gestational age of 37 weeks or more as preterm. So think about what this means. If you spot a provider documenting late preterm for an infant born at 37 weeks and a few days, you absolutely cannot just code it as prematurity. Doing so is a major compliance error. Instead, you have to compliantly query the provider for a more precise diagnosis. You need to ask them, hey, is the infant actually small for dates or light for dates? Because honestly, ICD-10-CM simply doesn't have a classification for a late preterm infant who is beyond 36 completed weeks.
Now, if the infant is exactly 36 completed weeks, this highly specific code, P07.39, preterm newborn, gestational age 36 completed weeks, is your absolute mandatory selection to ensure precision. This code explicitly covers newborns from 36 weeks and 0 days through 36 weeks and 6 days. Capturing this exact week of gestation is a massive factor. It's literally the key to routing your claim to the correct MSDRG family for prematurity, distinguishing between those with or without major problems, like MSDRGs 791 and 792.
Section 3. Meconium and high acuity conditions. Let's look at the complex newborn conditions you'll frequently encounter that elevate these cases into those higher-weighted groups, like MSDRGs 793 and 794. We're talking about looking out for respiratory distress syndrome, or RDS, necrotizing enterocolitis, hypoxic ischemic encephalopathy that requires therapeutic hypothermia, and neonatal abstinence syndrome. Every single one of these requires precise, verified documentation to separate a case of uncomplicated prematurity from a neonate facing major problems. Take meconium staining, for example. On its own, it is not a major complication. To actually code for meconium aspiration syndrome, or MAS, you have to dig into the record and look for specific clinical indicators. We're looking for apnea, bluish skin, obvious respiratory distress, and limpness at birth. Without these documented signs of distress, an auditor will absolutely strike the MAS code down, and boom, your reimbursement goes right out the window with it. It's also crucial to remember that we often have to trace neonatal distress back to maternal perinatal conditions. It's like putting together a giant puzzle to get a complete chart. Take chorioamnionitis, an infection of the membrane surrounding the fetus. When a mother has this, it fundamentally alters the risk profile for the newborn, often triggering severe sepsis or respiratory distress that mandates immediate escalation of care in the NICU. Section 4. Perinatal procedure coding.
Switching gears to the surgical side, in the ICD-10 PCS system, the obstetric section, which always begins with the character 1, is completely unique. And why is that? because the targeted body parts are the products of conception. We aren't coding the mother's uterus here, guys. We are coding procedures performed directly on the amnion, the umbilical cord, and the placenta.
This breakdown perfectly illustrates how critical the seventh character, the qualifier, is in these procedures. Let's look at the root operation of drainage. If you're draining fluid to test it, like in a diagnostic amniocentesis, your qualifier is U for diagnostic. But let's say the uterus is compressing due to excess fluid and you do an amnioreduction to decompress the womb and prevent a preterm delivery, well, now your qualifier becomes C for therapeutic. And if you're draining fluid specifically for fetal blood sampling, that qualifier changes to 9. Missing this tiny detail changes the entire nature of your procedure code.
Section 5. Sepsis Clinical Validation.
Before we even touch the ICD-10 codes, our clinical documentation integrity, or CDI specialists, really need to clarify ambiguous physician language. The phrasing ruling out or rule out an infection means the physician suspects the condition is actually present on admission, and we often code for it and its associated symptoms while the clinical workup continues. But an infection that has been definitively ruled out with an ED, that means the condition is confirmed to not be present and it absolutely cannot be coded as an active diagnosis.
As you map out that principal diagnosis, you've got to remember that neonatal sepsis operates under totally different rules than adult sepsis. You must use the P36 series codes. These combine the infection and the organism into a single code, like P36.4 for sepsis of newborn due to Escherichia coli. From there, your next step is to identify if severe sepsis is present and then sequence the localized organ dysfunction, like an acute kidney injury, to fully support the medical necessity of a high-severity NICU stay.
Now, if a commercial auditor attempts to downgrade your neonatal sepsis claim just because of negative blood cultures, you have to defend it with hard clinical indicators. Positive cultures are not always required if the overall clinical picture is overwhelming. You need to point to things like temperature instability, not just high fevers, elevated inflammatory markers like CRP or procalcitonin, and the prolonged duration of IV antibiotics. Tying these systemic indicators directly to the physician's diagnosis is your absolute strongest defense against revenue loss.
Summary and next steps. Let's wrap this up. We've seen how precise birth weight documentation, the Z38 birth status code, and discharge status really form the foundation of neonatal DRGs. We learned that strict adherence to gestational age rules, especially that hard 37-week cutoff for preterm coding, will save you from massive compliance errors. We reviewed how PCS qualifiers completely change based on the specific fluid drained, and finally, we saw how robust clinical validation is your best defense against those pesky neonatal sepsis downgrades.
So I want to leave you with the question. Think about your current workflows. Are your CDI queries truly robust enough to capture the clinical indicators necessary to defend against auditor downgrades? It might be time to review your facility's NICU documentation practices today. Make sure to join us for Part 10.6, where we will dive into the Advanced Surgical DRG Deep Dive, Major Diagnostic Category 15 Neonatal and Pediatric Surgical Procedures. And finally, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.